First off, I would just like to do a little bit of housekeeping. If I can ask those who are in attendance just to make sure that their the microphones are on mute, just because obviously that helps with any interference or prevent interference while the speakers are presenting. And also during the session, if you're having any issues with connectivity, then you can turn off your video cameras if you have those on, and you'll be able to put speaker view on via Zoom by going into the button on the top right under view. You can then just put speaker view onto that. We will use the chat function for questions, and there's a series of presentations today. So at the end of each presentation, then I will open up the discussion. So if you have any questions, then please just type those into chat. And at the end of each session, then I will review the chat, and we'll go through the questions then, and any discussion can then develop from there onwards. So I think that's the key things. First off, I would really like to thank Leona Glinsky and her colleagues for delivering the BAC webinar today. And it really is a collaborative approach, as the poster shows there. So I'm going to hand over to Leonie, who's going to introduce some of her colleagues and the first presentation. So thank you, Leonie.
Thanks very much, Alison. And first of all, welcome to everyone, and thank you for joining us for this session today. I think it's the first BAC webinar for 2021. We're really excited here at the Royal Cornwall Hospital just to show you how important collaborative working is to improve diagnostic pathways, but also in research as well. So thank you to the BAC for allowing us this session today. Let's make a start with our first presentation, which is called the Pancreas Cooperative. I'd like to introduce Dr. Dush. He's one of our consultant radiologists, Dr. James Garvacan, who is our lead consultant cytopathologist and histopathologist, and also myself, who's the senior biomedical scientist in cytopathology. So I'll hand over to you, Dr. Shetty.
Thank you, Leonie. Thank you to Leonie and her team for inviting me to speak. It's a great honour to be here. And I realise I'm very much the appetizer in this great feast we have this afternoon, so I promise to be brief. As Leonie said, I'm one of the GI radiologists, and as part of this, my remit is also in endoscopy and endosonography. And for those who are unfamiliar with endoscopic ultrasound, it is essentially an ultrasound at the bottom of a scope that allows me to assess and sample subepithelial lesions anywhere along the esophagus all the way to the duodenum, as well as looking at adjacent structures in the thorax and abdomen. And this could be biopsying posterior mediastinal masses or lymph nodes from lung cancer, lymphoma, granulomatous diseases, left adrenal lesions, left-sided liver lesions, perigastric masses, or pancreatic masses. Pancreatic masses are either solid masses that require a biopsy or cystic lesions that require aspiration for diagnosis plus or minus drainage. As you can see from this image here, the majority of the pancreas can be visualized from the stomach with endoscopic ultrasound. The head and uncinate process is much better visualized from the duodenum. We can also look at the extrahepatic bile ducts from the duodenum all the way from the ampulla up to the bifurcation. The setup in our institution is a bit like this. That is the EUS scope, and the scope is the size of an adult thumb for those that are interested. The luminal GI image is opposite, and the sonographic image is just there. The patient lies obviously on the bed facing me, and I'll be standing about here. And in the corner of the room is our ROSE setup, which Leonie will go through in detail in due course. So we'd like to present the case of a 30-year-old gentleman who presented in 2017 with a right thigh mass and pain that was biopsied under ultrasound guidance and unfortunately found to be a sarcoma. This was then resected, and following which he had a period of high-dose adjuvant radiotherapy. About a year later, a year after his initial resection, on his staging CT scan, there were 2 pulmonary metastases, one of which was ablated and the other one was resected with curative intent. And in 2020, he presented acutely to our medical team in obstructive jaundice. So the first test he had was an MRCP, a magnetic resonance cholangiopancreatography, and this gives us 2 kinds of images. The one on the right here is a road map of the biliary tree. It's what we call a radial thick slice, and as you can see here, that's the left hepatic duct, that's the right hepatic duct, that's the extrahepatic duct, the common hepatic duct, and where the cystic duct joins, you've got the common bile duct. These are all dilated, and as you come to the mid portion of the common bile duct, you can see there is a paucity of signal. He's got a long stricture extending from the mid CBD down towards the ampulla, which is here. Now, if we look at the axial slices on this T2 MRCP, that's the pancreatic gland. There's the pancreatic duct in there. You've got a little bit of fluid around the pancreas. And in the head of the pancreas, you've got this heterogeneous, hyper-intense mass responsible for the biliary obstruction. Now, the first interesting thing to say about this image is that contrary to the majority of pancreatic ductal adenocarcinomas, there is no pancreatic duct dilatation and there is no pancreatic gland atrophy, which we see in the majority of pancreatic ductal adenocarcinomas. The patient went on to have a CT scan, and at this point he's had his biliary tree stented to relieve his jaundice. So that's the biliary metallic biliary stent that runs right along the course of the CBD from the ampulla up towards the bifurcation. On this image here, you can see there's a hypoattenuating abnormality with some contact with the vein medially. That's the remainder of the pancreas, spleen obviously in the left upper quadrant, liver, and you can see the tops of both kidneys there. And as I scroll through, you can see he's got this heterogeneous mass that's going all the way around the stent, and that's why he presented with obstructive jaundice and causing his biliary obstruction. So he had a staging CT which showed this pancreatic mass, but no other disease foci anywhere else in the thorax, abdomen, and pelvis. And he went on to have an FDG PET scan. And at a similar level to the CT scan, if you look at this fused FDG CT PET scan, you can see that the mass is photopenic. There is no avidity whatsoever within the mass, which, again, going back to what pancreatic ductal adenocarcinomas normally do, the majority, they are usually FDG avid. So this is slightly odd if within thinking about that differential. The other thing to note is there is no abnormal avidity anywhere else in the neck, thorax, abdomen, or pelvis. So we have somebody with a history of malignancy who's got a mass in the head of his pancreas. Based on all the imaging we've done, it is it's unifocal disease. We haven't got any disease elsewhere. And the differentials at this stage are of a ductal adenocarcinoma, although atypical, as I've already discussed, a pancreatic neuroendocrine tumor, a metastasis, obviously given his history, or what we would consider a pseudotumor, an inflammatory process, although this is very unlikely on the evidence that we have so far. So the next thing to do is to try and get some tissue, and the best and safest way to do that is via an endoscopic ultrasound. So the first image here is of the pancreas. I've got the scope down into the stomach and I'm up against the greater curve of the stomach, and you can see this is the pancreas here, and this is what it looks like on endoscopic ultrasound. Some textbooks describe it as a salt and pepper appearance. That's the pancreatic duct there, which is not dilated, and the splenic vein posterior to it. Going slightly further down, that's the mass in question in the head of the pancreas. So at this point, I've gone through the pylorus and I'm within the duodenum, and you can see posteriorly it's compressing the portal vein over just over 15 millimeters and in contact with the portal vein over about 27 millimeters. Now that is really, really crucial when it comes to MDT discussion and speaking to the hepatobiliary surgeons about resection and potential resection. Anything more than about 25 millimeters of portal venous compression is beyond their ability to graft, and that goes from being what we would consider borderline operable to inoperable. So it's really important to delineate the anatomy, which we can do at endoscopic ultrasound. Following this, I'm able to pass a 22 gauge needle into the mass from the duodenum. The needles that we use are Procore needles made by Cook, and we can go from a 19 gauge all the way up to a 22 gauge depending on the clinical need and the clinical suspicion at the outset. So the needle goes into the mass and it fans through the mass at various angles to try and sample as much of this mass as possible. And for each pass, I fan through about 25 to 30 times as tolerated by the patient. The needle then comes all the way out of the scope and is handed to Leonie. And at this point, I will hand over to her.
Thank you, Dr. Shetty. Well, the rapid on-site evaluation RCHT is provided by a single biomedical scientist, and we use a technique called the single slide assessment. And this means that the entire pass is put into the head of a universal, it's mixed, and we take a representation to look at the morphology there in the clinic. But before I've even got that far, when I first arrive in the clinic, I need to know what's the question that we're trying to answer as a team here. And it's really, really useful that with Dr. Shetty, he will go through the images and he will explain the radiology and the clinical findings. So it helps me narrow down exactly what I need to play my part. And obviously we're dealing with a young male here with a history of primary sarcoma, and he's got a new pancreatic lesion in the head of the pancreas. And the question is, what is it? So that then gets me thinking in my mind as a Rose, what do I actually need cytologically to help establish the diagnosis? But I've got to keep it in keeping with the clinical picture and the radiological findings. And also what's key here is the discussion, what happens in the discussion before we start the procedure is Dr. Shetty will explain where he's going through to actually sample the pancreas so that I'm aware of any potential diagnostic pitfalls such as gastric contaminant sampling or sampling from the duodenum. And all of this is vital prior to conducting the procedure. I'm also armed with the algorithm that we use here at Royal Cornwall Hospital. So at the top, you can see that Rose is the initial assessment is done on morphology, and we all know in cytology, morphology is key. So if there's nothing there to assess morphologically or it's insufficient on morphology, we go back and we repeat the pass. If I think there is material there that is diagnostic, and whether that's benign or lesional, or whether that's malignant, it then takes me down the two other arms of the algorithms. For the malignant arm, the differentials that I need to consider based on the morphology, if I'm thinking lymphoma could be on the differential, we have larger needles that we can use to make sure that we get sufficient material for the large immunopanels that are required. If I'm thinking that it could be a pancreatic neuroendocrine tumor, then I need the immunohistochemistry for typing, but also for proliferation markers. Or if it's something a bit rare, some kind of metastatic disease, for example, metastatic melanoma, I need to make sure that I have sufficient material for immunohistochemistry and any molecular sampling such as BRAF. So I'm not just there to say, yes, we've got diagnostic cells. I'm there to say we've got diagnostic cells and we've got sufficient cells to do any ancillary tests that we need to prevent the patient having to come back for further investigations. Next slide. So this was pass one. So you can see we've got some really paucicellular, really scanty slide with a few cells that are really not giving anything away, with a bit of blood in the background and an inflammatory cell. And we have to go back to our question, is this going to provide us with an answer? It's really not, no. So we did another pass. And this is what we got on the second pass. So we got these sheets of these ductal cells. Now we have to go back to the radiological and the clinical information here on the differentials. So there's two possible differentials with this. Is it contaminant ductal epithelium, or is this a well-differentiated adenocarcinoma? But we've already established with the radiology that that's unlikely. And also he's 31 years old, so that would be incredibly rare in that age group. But just for confidence as well, with the differential of ductal adenocarcinoma, you would expect to see some atypia. You would expect to see drunken honeycomb sheets of cells. You'd expect to see nuclear pleomorphism, and you don't see it in these. These are nice, well-organized honeycomb sheets that are monomorphic and regular. So this is not going to answer our clinical question. So we went on to pass 3 and things started getting a little bit more exciting. You can see that this slide is extremely busy, and when we go on to higher power, next slide, you can see that these cells are small, oval, monotonous. They've got very, very little cytoplasm, and in some cells you can just about make out a discrete nucleoli. Some cells have none at all, and you can, it'd be fair to say in this presentation, they do look a little bit neuroendocrine in appearance. So from our differentials, we've kind of excluded ductal adenocarcinoma, and we've got 2 other areas that we are now launching into with pancreatic neuroendocrine tumours. I've seen a few of these in pancreatic rows, and you know, the morphology that we've seen in the cells would not be, is kind of in keeping, you know, the small ovoid, medium-sized cells without prominent nucleoli. But also we have to remember his differential, and I am no expert in sarcoma and the rare diagnosis in the EUS and pancreatic. So there's a moment of panic that sets in because actually there's a significant overlap for these pancreatic neuroendocrine tumours and sarcoma. They both have monotonous cells with scanty cytoplasm and inconspicuous nucleoli. And I have to remember, though, I'm not there to make a diagnosis. I'm there to make sure I have sufficient material. But I'm panicking because I'm not 100% sure what I'm looking at. Next slide. And after the panic, we take a breath, we go to our happy place and we calm down because we know we have their algorithm. We have the algorithm. Next slide. And in our algorithm, when we've gone down the diagnostic cells that are possibly on a malignant arm, if it's pancreatic neuroendocrine, I know that I need enough material for immunohistochemistry. But if it's something rare, which it could well be in this scenario, I need to make sure I've got enough for immunohistochemistry and any molecular tests. And by pass 4, I was happy that we had sufficient material to do anything that we needed to, even for the weird and the wonderful cases that we might come across. And we do need to remember also in pancreas as well that you have to be absolutely confident in your Rose decision, because you want to sample the pancreas as few times as possible to reduce the likelihood of causing pancreatitis. Next slide, please. So when the sample comes back to the lab, we automatically produce an LBC PAP and an induced clot with thrombin and plasma. And so this is just a slide to demonstrate the cells seen in the PAP presentation. And you can just about make out in a few of those cells some sort of more prominent nucleoli. But again, the same features as we saw on the Ginza earlier at Rose. Next slide. And then I can breathe a sigh of relief when I see the clot that comes through, and we've got abundant cells to do lots of testing with to get to a comprehensive diagnosis. Next slide. So my role in this pathway is complete, and I'm satisfied that I have taken in all the radiology information. I've made a report of my Rose findings, and I've got sufficient material to help the consultant histopathologist complete the diagnosis. Next slide. And so by the time it does get to our consultant histopathology, they have a wealth of knowledge. They've got optimally preserved samples. We fix the samples immediately in clinic, and the alcohol fixed straight away. And we triage the sample to make the best preparations so that the consultant can go on to make that diagnosis. And it's at this point I'll hand you over to Dr. James Garvican.
Thank you very much indeed, Leonie. It's easy when work has been presented to you. Well, easy is a strong word, but it's easy when work has been presented to you in such an expert way, with a large volume of material which has been yielded from the procedure and then prepared and preserved in a way that we are able to do a wide variety of tests if we need, because as Leonie said, this case had a number of features which definitely fitted into the PNET category, and some other features which fitted into the sarcoma category. So the question is it important to distinguish between the two? Well, clearly it is in terms of potential prognosis and potential novel treatments which may be available down the line. So how are we going to start to sort that out? Well, we start again with the morphology and reviewing the slides that Leonie has prepared, and the cell plot, which is on the next slide, please, Tish, which possibly has some branching vessels with with an eye of faith and a possible Staghorn-like appearance. However, some of those cells are also still looking quite neuroendocrine in appearance. And on this slide and on the next slide, please, there are a few possible mitotic figures around. So we're not entirely sure what we're dealing with. But at this point, it is a case of back to the happy place, deep breath, review all of the information that you've been given, because in my experience, when cytologists try and do things all by themselves, they get into trouble very quickly. So we work together as a team. So going back to the previous history, we were able to review that this patient did indeed have a past spindle cell sarcoma, which was proven to be a synovial sarcoma on FISH translocation. Next slide, please, Tush. With a number of immunohistochemistry markers which had been performed on a much larger sample. So next slide, please, Tush. So by judiciously repeating a few of these cells are positive for BCL2, they're weakly positive for CD99, but there is definite positivity there. And of note, there was complete negative staining for cytokeratins, for chromogranin, for synaptophysin, and a few other markers that we threw in, just to be, absolutely certain and belt and braces. So this is a case of metastatic synovial sarcoma, which is a proper hen's teeth diagnosis, and I'm sure probably the only case of metastatic synovial sarcoma in the pancreas I will diagnose in my career. But we're pretty certain that is indeed what it was. And so next slide, please, Sush. So the next phase is, of course, with any tumor site like this, the regional review and the regional sarcoma MDT to make a decision about ongoing treatment. And the treatment intent for this 30-year-old gentleman remains curative, and he commenced neoadjuvant chemotherapy ahead of an attempt at metastatectomy. Thank you.
Okay, thank you very much. That was a really interesting case, and as I say, quite rare. So it's really good to be able to see these cases presented. And again, really exciting or interesting photos as well. The images are lovely. So thank you for that. Is there any questions from the audience? There's nothing in chat at the moment, but if anyone has any questions for the team.
Yes.
Nothing yet.
Yes, I have a question. My name is Philippe Viel. Did you check the translocation by FISH?
I don't think we did recheck the translocation by FISH, Philippe, on this case. There was plentiful material left in the block, and there remains plentiful material left in the block. If the clinical team was to decide that that was required in the future, but the clinical and radiological pictures and the MDT discussion were all entirely in keeping with this being metastatic synovial sarcoma.
Thank you.
Okay, thank you. Are there any more questions? Again, I think it was a really good example of specimen management as well, with the on-site assessment to make sure that there was sufficient material for that downstream analysis as well. So it's a really good case to showcase that. So if there's no other questions, I think we'll move on to our next speaker, if that's okay. So our next speaker is Dr. Ben Rock. He's a consultant radiologist, and Dr. Tim Bracey, consultant histopathologist. And we also have Dr. Venkat Reddy, consultant ENT surgeon, and they're presenting a case from virtual neck lump. This is a pre-recorded presentation, but I'm sure if there are any questions at the end, the team might be able to answer any questions on that. So thank you.
Good afternoon, everyone. Thank you very much, Leonie, for inviting us to speak at this British Association of Cytopathology webinar. We are Dr. Tim Bracey, myself, consultant pathologist. We've got Venkat Reddy, consultant ENT surgeon, and Dr. Ben Rock, who's the consultant radiologist. And we're going to present a case of a neck lump from the context of our virtual neck lump clinic.
So this was a patient that presented to the ENT suspected cancer clinic, where we have ultrasound scan by radiologist or radiographer and a cytotechnician to assess the adequacy of the specimen. The patient had a 3-month history of a right-sided neck lump, with also progressive pain in the right cheek and right ear, which was getting worse when they were chewing. So in keeping with our usual management guidelines for neck lumps, following a clinical assessment, an ultrasound scan of the neck with fine needle aspiration for cytology was performed in clinic by a radiologist with rapid on-site evaluation.
So this is the ultrasound that we performed in clinic. Ultrasound can look a bit like a snowstorm to the uninitiated, but I'll try and take you through it. So this area here is the normal looking right parotid, and it normally has this kind of slightly bright appearance. This is the mandible here, and this is the masseter muscle overlying the mandible. And then if we just look superficial to the masseter muscle, we start to see this hypoechoic area, which is the lump that the patient was feeling. So here we go, it's within the superficial part of the parotid gland. This is the superficial part of the parotid gland curving over the masseter muscle, and there's this hypoechoic area, which is just bulging superficially from the parotid capsule. As we move a bit further forwards, we can just see the edge of the lesion here. Here's the masseter muscle. The duct would normally run over the masseter muscle here. If we just scoot on a couple of pictures, we can see that the lesion is extending quite far anteriorly over the masseter muscle. It looks a little bit irregular. So these appearances are really quite non-specific. You could see this, for example, with an inflammatory process. Inflammatory processes can look quite irregular and ill-defined. It also could, at this point, represent a neoplasm. So really, FNA would be essential here to kind of triage and guide further management. So our normal practice would be to go on, perform an ultrasound-guided fine needle aspiration, and we're very fortunate to have the facility to do rapid on-site evaluation. So we get an instant result as to whether we've got adequate material. If not, we do have the option of performing a core biopsy, but that's not without risks within the parotid gland. So FNA is a great first-line test.
Okay, this is extremely low power view of a diff-quick stain of the very cellular FNA, and at this low power you can't really make out any cytological detail, but you can appreciate that there are rounded lumps of stromal material and a lot of dark blue cells that are lining those stromal clumps. And then at higher power, you can appreciate that stromal material is sometimes made up of rounded and tubular clusters of this quite deep magenta purple staining material. And then it's coated with these very dark cells that are only slightly bigger in that view than the red blood cells that are scattered around. And then this is a slightly higher power view showing that these stromal clumps of magenta material, extremely well demarcated edges to them, quite crisp edges, almost cut out with a sort of cookie cutter appearance. And then there are these round to oval, quite dark staining tumor cells surrounding, which have very little cytoplasm at all. There's no necrosis or obvious mitotic activity. So at this point, you should be presented with a voting screen. So these are the differential diagnoses which we're putting forward for you to choose for your favoured diagnosis.
Okay, we'll just give that a few seconds for a few more votes and then we'll close that.
So,
okay, so the overall percentages, we have 32% for pleomorphic adenoma, 66% for adenoid cystic carcinoma, and 2% for polymorphous adenocarcinoma.
as is usual with these patients, we discussed the case at the head and neck multidisciplinary team meeting following getting an MRI scan and a CT scan. And we also did a core biopsy for further evaluation. So I'm going to let Ben talk about the investigations.
This is the MRI scan that we performed. We'll run through a couple of sequences here and I'll just try and explain to you what we're looking at. So this is a T1 weighted axial sequence. And as we come up through the neck, we'll eventually get to the parotid glands. T1 is a really great sequence for trying to identify the extent of pathology, particularly within the parotid glands, because the parotid glands tend to get infiltrated with fat. So you see pathology nicely outlined against the fat. So this is the lump that we were seeing on the ultrasound appearing as this dark mass against the bright parotid gland here. Here's the normal parotid gland on the left-hand side. So we can see the lesion overlying the masseter muscle and the ramus of the mandible here. This is actually the retromandibular vein, and the facial nerve will be running in a plane roughly along here. We can just see the facial nerve actually coming out of the stylomastoid foramen there. So the lesion is extending towards the facial nerve at its deep aspect. So that gives us some idea about the lesion extent. We want to try and characterize this a bit better now, so we can do various different sequences. T2 weighted sequences can be useful in characterizing parotid lesions. In general, benign lesions tend to be very bright on Te2 weighted sequences. The story that we're told as radiologists is that they tend to be quite watery lesions, and darker lesions tend to be more cellular. So we tend to get a little bit twitchy if we see darker lesions on the T2 weighted sequence, and this is quite dark. This is CSF here, so that's fluid signal, and this is darker than fluid signal. So there are some worrying features on that T2 weighted sequence. We also like particularly for salivary gland pathology, and that's because contrast can more accurately delineate the extent of particularly tumours, and particularly in the context of perineural spread. So if we have a look at the mass on this fat suppressed contrast enhanced sequence, we suppress the fat because otherwise the fat is bright and the enhancement's bright. So we get rid of the fat signal, and then we're left with the white signal of the tumour. We can see the tumour here, and there's this little strand of enhancement which is extending anteriorly over the masseter muscle here. We'll come back to that in a second. And there's also this strand of enhancement which is extending around the posterior aspect of the ramus of the mandible, and you can follow it around here, and it's actually splitting around this this dark structure here. And this is actually the middle meningeal artery, and the structure that takes that course and splits around the middle meningeal artery is actually the auriculotemporal nerve, a branch of the mandibular division of the trigeminal. So this process is following the expected path of the auriculotemporal nerve. If we have a look on the coronal sequences, again, we get really nice volumetric coronal sequences on this contrast enhanced sequence. It lets us sort of map the extent of enhancement really nicely. We can see this strand of enhancement extending over the right masseter muscle, and this is actually following the expected course of the buccal branch of the facial nerve. So the facial nerve divides into 5 branches, the pes anserinus, and it's extending here along the buccal branch of the facial nerve. As we come back, we can follow that strand of enhancement that we saw before. This is the foramen ovale. So there's enhancement extending up the main trunk of the mandibular division of the trigeminal nerve towards the foramen ovale. So on the basis of this MRI, it really looks like there is evidence of perineural spread of the pathology. So now, really, we're into the realm of malignant pathologies. So I would be worried here that this is a malignant salivary gland tumour. The things that we see do this on imaging. Various tumours will do it. So, for example, squamous cell carcinoma is the commonest tumour that we see doing it within the head and neck. Melanoma can do it, lymphoma can do it, but particularly in the context of salivary glands, the tumour that is renowned for doing this is adenoid cystic carcinoma. So radiologically, at the moment, my differential would be of a malignant tumour within the salivary gland with possible histological diagnoses that I've just mentioned.
Thanks, Ben. So Ben went on to do a core biopsy, and that has actually confirmed adenoid cystic carcinoma. So the panel on the left-hand side shows the classic histological cribriform pattern of adenoid cystic carcinoma infiltrating the parotid parenchyma, which is just pictured above the tumour itself. And those cribriform patterns are surrounded by an outer layer of more clear myoepithelial cells, and that makes the histological diagnosis quite clear, particularly when perineural invasion is identified, which was very florid in this case, and that's pictured on the right hand side with this swirling pattern of the tubules and cribriform pattern surrounding those nerves. We're going back to the voting possibilities. Pleomorphic adenoma I'll move on to in a second, but always has to be on a differential of a parotid mass being by far the most common tumour we encounter in that area. Squamous cell carcinoma is actually quite common in the elderly population to present in the parotid, usually as a secondary from skin cancers on the head and neck. And then adenoid cystic carcinoma turned out to be the correct diagnosis. Polymorphous adenocarcinoma is immediately out because that's a minor salivary gland tumour, almost exclusively found in the oral cavity, usually the palate. Epithelial myopithelial carcinoma is fortunately rare because it can mimic adenoid cystic carcinoma, both cytologically and histologically. But generally on cytology, the features that resemble adenoid cystic carcinoma are only seen in one small area. And generally, there'll be some clear cells as well within that cytology aspirate. So I just wanted to point out the differences between pleomorphic adenoma and adenoid cystic carcinoma, because both are relatively common in a general cytopathologist's workload. So on the left, there's the stromal material that you get with pleomorphic adenoma, which accompanies the tumour cells. So in that way, there is a bit of a crossover. You get with cytology FNA, you get a mixed stromal and tumour cell pattern in both tumours, but the stroma is much more. We sometimes talk about textures with visual things, which is an odd thing to say, but the stroma is much more wispy and almost like candy floss. Although it is the same colour as the adenoid cystic carcinoma, stroma is much more fibrillary. Metachromatic stroma, and the tumour cells are often mixed in with that stroma rather than congregated on the outside of the stroma like you get with adenoid cystic. The tumour cells are often quite squashed and difficult to see within that stroma, but even when the stroma is scanty, which is quite often the case with pleomorphic adenoma, it can be epithelial rich rather than stromal rich. And on the right panel, these sort of more plasmacytoid cells where there's much more cytoplasm, and the cytoplasm is eccentric, and then you get occasional large anisonucleotic cells within pleomorphic adenoma, which is not a worrying feature. And in fact, those plasmacytoid cells with the metachromatic stroma is virtually diagnostic of
Okay, I think, have we finished that recording. I don't know if Lean is there. But again, that was a really interesting case to see. I think we might have lost connection there with Leanie. Does anyone have any questions? I understand that Dr. Bracey might be available to take questions. Are there any questions from attendees?
Yeah,
Again, I just thought it was a real, yeah.
I have a question. Philippia speaking. Was the lesion painful for the patient?
Sorry, Dr. Bracey, you're on mute, I think. Sorry. There we go.
Everyone has to do that at least once, don't they?
Yeah.
As you rightly say, it's I think it's important for cytopathologists to be aware of the clinical presentation of adenoid cystic carcinoma. And from my experience, it's quite unusual to make a diagnosis of adenoid cystic carcinoma on cytology, and for the clinical team to not at least suspect the diagnosis. The lesions often are associated with nerve-like pain, and this patient had facial weakness and some pain as well from memory. And also the FNA itself can be, correct me if I'm wrong, certainly from my experience, maybe it was just my technique, but patients always found they had an electric shock-like pain on several cases that I've FNA'd myself anyway. It's a common presentation is to have some sort of pain with adenoid cystic carcinoma, and that obviously relates to the perineural invasion that's florid in this kind of lesion.
Okay, very good. I do have a couple of questions now. Would you always do core biopsy even if definitive ACC on cytology and perineural invasion on radiology?
Again, that's probably a question for my clinical colleagues, but I know that here it's usual to carry out a core biopsy for confirmation, particularly if the stage of the tumour requires a much more radical resection than would be done for a more indolent salivary gland tumour, for example.
Okay, thank you. And would you accept a diagnosis of ACC from a particularly cellular FNA cell block rather than a core?
Personally, I could be pretty confident of the diagnosis. I think it's always a clinico-pathological diagnosis, but I think if you've got adequate clinical details and a good cellular FNA, particularly with a cell block, I think it's one of those malignant salivary gland tumours that has a very characteristic pattern. And as I've mentioned during the presentation, I'm not sure if it had cut off by that point, but if you have that those stromal globules with hard cookie cutter edges to them, then that's seen in 80% of adenoid cystic carcinoma to my knowledge. The difficulty you have, of course, is if that stromal material isn't present, and that's the case in about 20% of adenoid cystic carcinomas. And then, of course, you have to entertain other diagnoses. Unfortunately, that includes things like basal cell adenoma, which are, of course, benign. Now, the cytology of basal cell adenoma is different. The one tumour which I've been almost caught out by is epithelial myoepithelial carcinoma, but of course, that also can show perineural invasion. So that's a very difficult differential diagnosis. But the case that I've seen where adenoid cystic features were seen was only in one very small area of the FNA sample.
Okay, that's grand. We've another couple of questions now coming in. Are you using the Milan system for reporting salivary gland FNAs?
Personally, I'm not. I'm probably a little bit old school. I need to get up to date, but I'm certainly in progress of reading it.
Okay. All right. There was a hope so at the end of that. Answer. Well, there was hope so at the end of that question. So, And then
always trying to improve.
Okay, that's fine. And then the final question, I think, is there any utility doing molecular studies for MYB, NFIB translocation in adenocystic carcinoma?
Yes.
Did someone say yes?
I did hear someone say yes.
Certainly beneficial in difficult cases.
Okay, very good. That's great. So I do think we may have a problem with Leni link there. So if everyone could just be patient with us for a couple of minutes while we check that and try and get her back on. And I'll see whether any of her colleagues are still on the call, because we may be able to skip the order if that's the case. So if you don't mind just bearing with us for a moment, we seem to have a little bit of a technical problem with the link there. So just give us a few minutes if you don't mind. I see Ben coming on there. Hi Ben, how are you? Okay, you're on mute at the moment, sorry.
The internet's just kind of not working in Trelawney at the minute. I'm happy to present it, but Leonie might have to click on the slides if she's got that. Okay. I'm on my phone at the minute.
Right, okay. We'll just give it a few minutes, see if we can get Leonie back into the call.
Oh, is Leonie off as well?
Yeah.
Sorry.
Alternatively, if Leonie wants to send me the presentation, I could share screen or yep. And I could forward them on then if that she has my email. So if she wants to do that, I could share screen and we could progress then with your presentation. I'm happy to move them on if that's the case.
Is Leonie going to be able to hear that though, being off?
No, but maybe.
I've just emailed Leonie, Ben and Alison, so I'm just waiting to see. Oh, yeah. I don't know if it's a real internet problem. I wonder if she'll get the email. So.
Hi.
Bye.
Sorry. Hi. The joys of technology. All of our internet seems to have gone down, so we're using Tim's remote. So apologies to everyone for that. Tim said that he was able to finish and deal with the questions. So as long as you're happy to continue, I'll try and sort out our connection in the background, but apologies for that.
No problem. And I think we might have missed maybe one or two of the slides at the end with the discussion, but we can always upload that onto our BAC website with the pre-recorded session. So that's fine. No problem. This is what happens, unfortunately, in our virtual world these days now.
The joys of COVID.
Exactly. So are you okay to share screen for Ben's presentation? Or do you want me?
Ben, do you have the presentation available to share?
So I was just saying to Alison, sorry, the internet's down this side of the building as well. So got it on a USB stick, but I'm not going to be able to send it you. So I don't know if the one I sent last week, you'd be able to upload that and just click through it for me.
Okay, the only laptop I have, because my computer's out of action, is Tim's, and I'm unable to email it to him. So I could come down to get the USB from you.
Yeah, is Susie available? Would she be able to maybe present first? Would that be okay?
She ironically came in because she thought her internet signal at home wouldn't be as good as the Trust internet connection.
So everyone's affected by this, is it?
It is.
Okay. Well, look, why don't we just take a few minutes break and we can just ask people to either take a comfort break, a refreshment break for say 10 minutes. Would that be okay, Leonie? Will that give enough time for us to?
I'll be back in contact to let you know where. Again, apologies again. I'll try and get.
No worries. We'll come back in about 10 minutes. So if we want to come back at what time?
Share, I believe.
That would be great. Thank you. So while you're sharing, I'll just introduce you. So our next speaker. So welcome back, everyone. And again, apologies for that. So our next speaker is Dr. Ben Probyn, and he's a respiratory registrar, and his presentation will focus on collaboration involved for successful research. And having respiratory medicine on board with the study really helps with recruitment and provides significant clinical input and relevance to studies. So we'll just wait for that to come on board. So there we go.
What do I have to do now?
Oh. That's great. Thank you, Ben.
Perfect, that's great. So as Alison said, apologies for the little technical hiccup there. I'm Ben Probyn, I'm one of the respiratory registrars, and I was going to discuss today some preliminary findings we've got from our KIWI study that I'm working alongside Lena Glinsky on. So there's a few different arms to the study, but one of the studies is looking at KRAS detection in blood and liquid-based cytology specimens. So just before I start, just as disclosures, so Biocartis Idealia are the sponsors for financial support for the cartridges to detect tumour markers in the liquid-based cytology specimens and also blood plasma. So the first slide I wanted to just show was the pathway of KRAS. So KRAS stands for Christian rat sarcoma viral oncogene, and it's an intracellular nucleotide binding protein, a G protein, which binds to small GTPases, and it exists in two forms: in inactive form, which is the RAS GTP form, and an active form, which is the RAS GTP form. Active RAS GTP complexes affect many downstream signaling pathways, as demonstrated by this slide. And these pathways are involved in multiple cellular functions, which includes proliferation, apoptosis, motility, and survival. And that brings us to our first poll. So what percentage of mutated KRAS is said to be detected in lung adenocarcinoma? Is it 1, 10%, 2, 20%, 3, 30%, 4, 40%, 5, 50%, or 6, 100%? So if you could vote now, I'd be grateful.
Okay, so we'll leave that just a couple of seconds for people to put the poll.
I'm hoping the polling still works. So do you have some responses?
No, yeah, we'll just give it another second. Are we okay, Christian?
Yeah, just give it a few more seconds. We've had about 55% vote so far, Ben. So I'll end the polling in just a minute. Yeah.
Perfect, thank you.
I'm now going to share the results, Ben.
Okay, so Ben, we have 23% of participants say 10%, 16% say 20%, 29% have selected 30%, 23% are 40%, and 10% 50%. So there's a wide range of results there. Yeah.
Perfect, and that makes sense, and I think that collaborates with the literature as well. So depending on which studies you look at, that there's a wide variability in prevalence of non-small cell lung carcinoma mutant KRAS reported, and it's variable between 6 and 46%. The study I popped on the paper that I did in 2013 that I looked at was the largest study that I found in terms of participants with confirmed lung adenocarcinoma, and they actually looked at 2,352 lung cancer cases and found that mutant KRAS accounts for about 30% of lung adenocarcinoma cases. So it is a significant proportion. In terms of squamous cell carcinoma, there was a lower percentage, 6.4%, and there's a lower prevalence among the Asian community compared to Western communities. Brings me on to my next slide. So, and this pie chart is demonstrating the incidence of KRAS mutations that we know about at the present. So the G12C KRAS mutations accounts for 44% of all mutated non-small cell lung cancers, and with the G12C, G12D, and G12V together combined, that accounts for 75% of mutated KRAS detected non-small cell lung cancer. And the RAS gene mutation occurs in exon 2 and 3, and essentially it impairs the GTPase, which promotes active GTP formation. So that leads to a gain of function and promotes tumorigenesis, which links to the slide I demonstrated earlier about the different signaling pathways. And you can imagine if the pathways that lead to proliferation are turned on and there's a gain in function, then that could promote tumorigenesis. As I said, so looking at the G12C KRAS mutation, that's the highest incidence of KRAS mutations in non-small cell lung cancer, and it's thought to account for up to 13% of all non-small cell lung cancer mutations. So it is a significant proportion. The KRAS mutation is important in terms of prognosis, as it's felt that mutant KRAS has a worse outcome in terms of progression-free survival in response to chemotherapy and immunotherapy agents. Likewise, the variability in the mutant KRAS may affect which kind of the oncogenic phenotype in terms of things like site of metastases, and is thought to affect both progression-free survival and overall survival. Okay. And the other thing that's quite important is that we look for other molecular markers such as EGFR, ALK, and ROS1, and it's thought that the KRAS mutation is meant to be exclusive to these mutations. So that is important when it comes to therapies, which I'll come on to later. So my next poll, are there any KRAS specific targeted treatments? So there should be a poll come up now. So if you could all vote.
That poll has come up, so we'll just give it a few seconds, Ben, just to allow people to submit their answers.
I'll give just 10 more seconds, Ben, and then I'll end the poll.
Perfect.
Okay, so 84% said yes and 16% said no.
Perfect. So the majority wins in this case. So there's an agent called Cytology that's just gone through phase 2 clinical trials, and I've just popped the press release report here. So there's kind of two things that I wanted to bring to mind. So historically, studies have been really disappointing in terms of targeting the KRAS mutated form in terms of progression-free survival and overall survival. This agent form that's been manufactured by Amgen is the first in-class molecule to specifically and irreversibly inhibit the KRAS G12C mutation. And looking at this slide, you can see that the news report was only released late last month. And looking at the patients that they incorporated, so the agent induced a 6.8-month median progression-free survival, which is very remarkable. And the patients that they incorporate into the groups was many patients that had progressed despite first-line treatment. So this marked response has led the FDA to approve the drug for real-time oncology review pilot to try and get it improved for kind of everyday use. And I think it's important to note that sotorasib response was observed across a range of the biomarker groups, so PD-L1 negative and low status STK11 mutations, which are known to be linked with poorer outcomes. And in terms of tolerability, let's just say that the majority of the treatment-related adverse effects were grade 1 or grade 2, and discontinuation rates for the drug was 7.1%. So that brings me on to just discussing about KRAS as a therapeutic target. So as you can see through my presentation, I've kind of highlighted the importance of the KRAS mutation and how mutated KRAS could promote tumorigenesis. So it's thought that if you've got a common marker that affects multiple pathways that by blocking that, hopefully you can block those different pathways. As I've previously mentioned, say if it's mutually exclusive to EGFR, ALK and ROS1, it means that those patients treated with inhibitors to these molecules might do worse, and it's often thought to be a negative predictive value for these patients or subgroups. So if we had an agent that could target the KRAS mutation, that would be really important. Furthermore, kind of the same sort of trail of thought, by blocking a mutated form of KRAS and leaving the wild type unblocked is thought to limit the side effect profile of pharmaceutical agents, and that kind of relates to why the treatment-related adverse events which led to discontinuation was so low in the study. And lastly, so obviously this morning we've talked about kind of different techniques to gain tissue diagnosis to then work on with different therapeutic agents. All these techniques, although they are minimally invasive, they're still invasive procedures that incur risks. And going forward with our study, if we was able to detect the KRAS mutation in peripheral blood, that would alleviate the need for invasive procedures in patients who have metastatic disease or advanced disease. So it's a really interesting marker and study to undertake. Looking at pancreatic cancer, so up to 20% of exocrine pancreatic ductal adenocarcinomas was found to have a mutated form of KRAS in the blood in the form of circulating free DNA or circulating tumour cells. So by using different techniques, we are able to detect this circulating free DNA, and really it's to look to see if we can validate it in terms of its sensitivity and specificity. And likewise, with my colleagues mentioned earlier that there was a move to fine needle aspiration over core biopsies because the risks are reduced in terms of the invasive procedures. And so we're trying to do more with the material we've got so that we can go on to targeted agents in the initiation of treatment. And so the cytology-based liquid specimens would allow for that, like the biocartis, which I'll come on to in a minute. That comes on to my next study. So what we're doing at RCHD. So currently we've got a QB study which has multiple arms. I'm going to focus mainly on the non-small cell lung cancer and KRAS arm of it. So we're looking at recruiting up to 200 patients with known pancreatic adenocarcinoma, and of that group we'd like up to 100 with non-small cell lung cancer. And what we're looking at doing is comparing using the biocartis ideally platform real-time PCR to detect EGFR, BRAF and KRAS in both the blood and liquid cytology specimens, and comparing that against standard molecular profiling, which often use the formalin-fixed paraffin embedded samples. And they can take up to 5 days to turn around the FFPE samples, whereas with the biocartis ideally we can turn it around in as little as 2 hours. So that's a markedly different time span to run through the samples and get molecular profiling, which we can then refer the patients on to the oncologist to think about starting treatment, should there be a treatment available, as we've talked about with the sotorasib. So the comparison arm is looking really at our standard with the FFP, which I've talked about, cytology specimens, and the outcome is really to see is mutant KRAS detectable in the peripheral blood on non-small cell lung cancers, at what stage that becomes detectable, and is that sensitive and specific? And likewise to look at the cytology-based arm with the CBL samples, comparing that against the standard with the FFP clot samples. So that brings us on to some of the preliminary results. So essentially we've got kind of our eureka moment here. So this is charts demonstrating fluorescence and cycles of amplification of the DNA, and the black line you can see that's the wild type KRAS detection with the biocartis cartridges, and the red line here you can see that we've managed to detect a G12C mutation in the plasma of one of the patients with non-small cell lung cancer. And when you compare it against the other mutations that we look at, you can see that's kind of a significant rise there, and the other mutations have low levels of detection. So you'd think that this is not a like a false positive because of over amplification, and you can see that that's got low levels of cycles to get that amplification, and you can also do the ratio between the wild type and the mutant type to kind of verify that. So just move this off. There was another detection of a mutation further down the line here, but that was required more amplification of the material to obtain. So at present, I'm not sure of the significance of this mutation. Sorry, and I'll just go back a second. No, sorry. There was another slide which also just demonstrated a very similar picture where we picked up the mutation in the cytology-based liquid specimens. So we are starting to show early promising results with the detection kit from Biocartis. So that really leaves us onto where we are and where we're going. So as I mentioned, we're starting to demonstrate the ability to detect the mutated KRAS in both plasma and liquid-based cytology specimens. We've got ongoing recruitment for this project, and that's spanning over 24 months. So at present, we've got about 20 patients with non-small cell lung cancer that we're going through and seeing if we can detect these mutations. As I've demonstrated, we are starting to detect them, and we can do a retrospective analysis to see at what subgroup of lung cancer stage in that we start to detect the mutations. And it'll be interesting, as I talked about at the start of the presentation, that there's variability in reported instances of mutated KRAS in non-small cell lung cancer. So it'll be interesting to see what our rates are locally down in Cornwall. And I think importantly, kind of another thing that we could look at potentially in the future is if we can detect this in blood when patients are started on agents for their non-small cell lung cancer, if they start developing either resistance to the drugs or recurrence, then we could potentially think about whether we could take peripheral blood samples to detect for KRAS mutation and see if that's the reason they're getting resistance, then switch the agents that we've got to mutated KRAS blockers. So that would be something that would be really exciting to look at in the future, although we're not quite there yet. And I think kind of all in all that we're starting to demonstrate that we are able to detect mutated KRAS in liquid-based cytology specimens and blood, although the plasma levels are shown at the moment in more advanced disease. And it looks like we've got well-preserved DNA samples which is demonstrating high quality reliable results. And it looks like we'll be able to do this with a quick turnaround of a couple of hours with the Biocartis cartridges, and rather than the traditional FFPE samples that can take up to 5 days. And it's something we can do locally. So I think it's very exciting times for this project. And this just brings me on to the references that I've used for my presentation. Any questions?
Okay, Ben, thank you very much. Again, that was a really interesting presentation there. It's good to see research as well going on in relation to cytology, particularly. I do have one question coming so far. What kind of cell block was used in the KEBI study? Was it thrombin and plasma? Recent papers state this method can be contaminated with plasma donor DNA.
Okay. I don't know if you want to take this. Sorry, I'll pass this over to Leonie.
I'm loitering in the background. Hello again. Yeah, it's an interesting question, and we had conversations. So we've been working closely with Biocartis, the Adilla manufacturers in Belgium, and the specificity that's required for the sequencing of the test that we're doing is not deemed to be affected by the plasma donor DNA, because the amount of cells that you need to get reliable results, you're talking hundreds with regards to the FFPE plots. So with the initial reviews that we've been doing with the experts in Belgium, it's not an issue with the test that we're doing, but it is definitely something that needs to be considered for future for highly specific tests. I hope that answers the question.
I have a question, Leonie, is what liquid-based cytology do you use? Is it ThinPrep or SurePath?
It's ThinPrep, yeah.
Yeah, okay. So again, that would be alcohol, and there'd be no formalin contamination then for the liquid-based cytology samples?
Absolutely, and what we're seeing is because the samples are alcohol fixed straight away, the DNA is preserved to a higher quality than we're seeing in the formalin fixed clots, because it's not going through the formalin processing. And there's the lowered risk of contamination. So when you're cutting sections through the formalin blocks, at every step there's a risk of contamination from other blocks, from other tissue. Whereas with regards to the LBC cytology, it's all contained within one pot and you load it straight onto the machine, so it eliminates the other areas where there's a risk of contamination. And when Ben was showing those nice clean curves, there was no amplification of the other curves, which is suggests that there's no contamination in those samples and they're clean and they're good quality samples.
That's great, thank you. Are there any further questions? Okay, I have one for Ben, if that's okay. Sorry, Ben, you mentioned the KRAS mutations, the different mutations. So is there work looking at different therapeutic strategies for the different KRAS mutations as well?
Yeah, I think that's a really interesting question, and I think that's in part of kind of what's muddied the water today is kind of when people have been looking at kind of negative predicted responses and values to chemotherapy and immunotherapy. There's been inconclusive data about KRAS mutations because they've taken them all together, whereas now we're starting to look at the different KRAS mutations. The sotorasib is only targeting against the G12C mutated form, and I think that's why they've got such good outcomes in terms of progression-free survival. Is that molecule they've developed only binds to that mutated form? It doesn't bind to other ones that I know about. So it's something that I think will hopefully be developed and looked at into the future, and especially if we can get kind of the 75% with the 3 different mutated versions covered, then that'll be a significant step forward. I'm not sure kind of in terms of the research that's going on if other drug companies are looking at the other mutated forms just yet.
Okay, that's interesting though, thank you. So thank you very much.
Sorry, Alison, I was just thinking as well, regards to the question with the donor issues. This is one of the benefits of actually doing it on liquid-based cytology, is that it eliminates the need for plasma and thrombin. So, you don't have that risk in the future of any donor DNA being present in the samples.
Yeah, that's great. Thank you. That's brilliant. So again, thanks again, Ben, for an interesting presentation. So, okay, that's great. Thanks. So our next speaker is Dr. Susie Hazeldine. She's going to present an unusual finding in pleural effusion and to demonstrate how clinical information is vital to help with morphological interpretation and immunocytochemical application in cytopathology. So thank you, Susie.
Hi, thank you very much. My name's Susie Hazeldine. I'm a histopathology registrar here in Truro. I'm going to present a case of an unusual finding in a pleural effusion. So this is our case study. It's a patient in their 60s with a left pleural effusion, and I'm not going to provide any additional clinical information at this moment, but there will be some relevant information later. So this is a high power view of our specimen. And as you can see, it's a very cellular specimen. There are clusters of cells, both small and large clusters. And if we zoom in closer, we can see that there are some background mesothelial cells. We've got these clusters of cells which have got quite rounded lobular outlines. And here on a higher power view, the cytoplasm is multi-vacuolated with quite fine vacuolations. There are large nuclei. And on the PAP stain here, you can see again these clusters, and I think we can appreciate at this power that some of the nuclei have got quite prominent nucleoli. So we're just going to pause for a poll here. What is your favoured diagnosis in this case? And here are your options.
Okay, Susie, the poll is up, so we'll just give it a few seconds for people to put their answers in.
Brilliant, thank you.
Hi, Susie. Sometimes it's nice to go back to the last slide, you know, so they can look at the cells again. But
oh yeah, that's a really good idea. I'll just I'll just skip back here. I'll just leave it on the PAP stain here.
brilliant. I'll give about another 15 seconds or so for results.
Thank you.
Okay, so the results are in. We have 3% are reactive mesothelials, 8% say they are metastatic papillary thyroid carcinoma, 59% say metastatic renal cell carcinoma, 30% malignant mesothelioma, and nobody has selected macrophages.
Okay, so the majority of people have said metastatic renal cell carcinoma, and that is ultimately the diagnosis in this case. But if you have said mesothelial cells or malignant mesothelioma, then you wouldn't be wrong here, because actually morphologically, it's not always possible to distinguish these entities, and I'll come on to that now in my pitfalls section. So this is the clot, and you can see that the clusters of cells we saw are well represented on this material. So we've done a basic epithelial mesothelial panel, and here are a few of our immunos. Calretinin is negative. We can just see a few positive mesothelial cells in the background. WT1 is negative. Paxate was positive. Oh, sorry, no, that's not Paxate. ESA was positive, and CEA was negative. So we did have some additional history, and this is where our multidisciplinary working really comes in. We had a history that this patient had a clear cell renal cell carcinoma, and we knew from the radiology that there were lung and bone metastases. Because of that, we did do some more specific markers on our panel. So we did a Paxate, which showed good nuclear positivity, and we did a CD10, which showed focal positivity in this case. So our diagnosis was metastatic clear cell renal cell carcinoma, and serous effusions secondary to renal cell carcinoma are rare. They account for only 1 to 2% of malignant effusions. And because of this, there is a lack of experience in recognizing this entity in effusion cytology, and there's also a lack of literature. Less than 2% of all patients with renal cell carcinoma will develop effusions. And although the features are well described in textbooks, there are very few studies which demonstrate their morphological features and the immunohistochemical features in metastatic renal cell carcinoma in effusions. So I've looked at 2 case series, and these series include clear cell carcinoma, papillary, and renal cell carcinoma NOS. They are small numbers of patients in each study, but the majority are clear cell carcinoma. The morphological features that they've described are that the cellularity ranged from few cells to abundant, and there was clustering in 50% of cases in one study, with the outlines varying from lobular to smooth. So it's important that we remember that in 50% there were no clusters of cells, they were just single cells, and that could make it even more difficult to identify this entity. The cells had abundant granular to clear cytoplasm in 90%, and large round nuclei with prominent nucleoli. In some of the cases of papillary renal cell carcinoma, there were papillae formation, but if these were absent, they did have very similar features to clear cell on cytology. So there are numerous pitfalls in making this diagnosis. The first pitfall is that the morphology is quite non-specific. So in some cases in these studies, the single tumor cells showed centrally dense cytoplasm and a lacy periphery, which could easily be misdiagnosed as reactive mesothelial cells. And also some had vacuolated or foamy cytoplasmic appearances, which could easily resemble macrophages. So this is one part of our case, and you can see sort of at the top here, there are a couple of reactive mesothelial cells, which also have some vacuolations in their cytoplasm. And in the middle here are our malignant cells. They're perhaps a bit more coarsely vacuolated with a bit more nuclear hyperchromasia, but you could easily get these two mixed up. Another pitfall is mimics. One study identified that diffuse malignant mesothelioma can be impossible to distinguish from metastatic renal cell carcinoma on morphology alone. And we know that there are also clear cell and sarcomatoid variants of malignant mesothelioma, which could make things even more confusing, both tumours having a heterologous appearance. This is just a standard case of malignant mesothelioma, which has been photographed. And these are some of the features of malignant mesothelioma on cytology. There are groups of varying size with scalloped contours. There may be papillary stromal cores, which could look similar to papillary renal cell carcinoma. And the cytoplasmic features include metachromasia, vacuoles and blebs, and large nuclei with visible nucleoli. This is a pap stain of the same case. So as you can see, morphologically, it would be potentially very difficult to distinguish those two entities. So the next step that we might take is to do a traditional epithelial mesothelial immunopanel to try and distinguish whether we're dealing with malignant mesothelioma or an epithelial malignancy. So for example, in our traditional epithelial marker panel, we might do a CEA, a Berry P4 and a MOC31. There are two case series in existence looking at immuno in effusion cytology of metastatic RCC. One found 0% were positive for CEA, 50% were positive for Berry P4, and the second study found only 27% were positive for MOC31, and all of those were papillary. Traditional mesothelial markers were more useful in that they were mostly negative. So calretinin was only 10% positive, and CK56 was 5% positive. So in these cases, mesothelial markers are more useful, but there's still potential, as we can see, for false positives. And the authors of these studies basically concluded that clinical information is really important here. It's essential to avoid these pitfalls. Specific immunohistochemistry markers might be less sensitive in metastatic renal cancer than in primary renal cancer. So one study found that RCC is only positive in 45% of patients with metastatic renal cancer in FNAs. CD10 is sensitive in 91% of the clear cell renal cell carcinomas, but other studies have also found it's positive in 50% of mesotheliomas. So if you weren't suspicious of renal cell carcinoma, you could easily make a misdiagnosis there. PAC8 and PAC2 are both were 100% sensitive for metastatic RCC in effusions in a study of 9 cases. They were also positive, as we know, for tumours of Müllerian origin, so they're not specific. In particularly difficult cases, it is possible to do genetic studies such as FISH on cytological material, and so you can look for loss of 3P in clear cell tumours or trisomy 7 and 17 in papillary tumours. So in summary, a metastatic renal cell carcinoma in effusion cytology might closely mimic foamy macrophages, reactive mesothelial cells, or malignant mesothelioma. General adenocarcinoma markers such as CEA, Berry P4 and MOC31 are not sensitive, and mesothelial markers are not always negative. CD10, PAX8 and PAX2 are the most sensitive markers, but as we know, they're not specific to this entity. And the most important thing is to have close clinical and radiological correlation and a high index of suspicion. Thank you very much to Leonie Glinsky for taking these really nice photographs, and to Dr. James Garbison, who originally reported this case. These are the references that I've used.
Great, thank you, Susie. And again, a fantastic case, another rare entity. And there's a comment on here about how beautiful pictures or images were, so very well presented as well.
That's
thank you. Does anyone else have any? Does anyone have any questions in relation to this case? No, we're just getting positive feedback here now. Susie, I have a question. Like, if that was the first presentation of this patient, then that would be quite difficult to make that differential diagnosis, would it? like you say, you really need that suspicion to fine-tune the immunohistochemistry panel.
Yeah, I think that's right. I think it would be, we did have that clinical information in this situation. The only epithelial marker that was positive here was ESA, and there's nothing really in the literature about how sensitive that is. So I don't know whether or not that would be positive in other similar cases. As far as I can see, that hasn't been studied. But if we hadn't have done more specific markers, I think it would be very difficult to come to that conclusion. I think the next step would have been probably to do CK7 and CK20, which would likely sort of lead us to the next immuno panel.
Maybe more a series of elimination rather than necessarily straight to a positive. That's great. But thank you very much. Really appreciate that. There's no other questions coming in there. So thanks again.
Thank you.
Thanks, Susie. Okay, so thank you everyone for staying with us today. We have one final presentation, and this is from Jared Little, who's a specialist biomedical scientist, and his presentation is on collaborative roles at EBUS and demonstrates how scientists play key roles outside of the laboratory as part of collaborative working in EBUS. So I'll hand over to Jared now.
Thank you. Is my screen sharing?
Not yet.
Oh, yes. 1 second.
Yeah, that's up now. Thanks.
Just trying to maximize it. There we go. So thanks, Alison. So as you say, it's about collaborative roles at EBUS. So the vast majority of EBUSs that we do at RCHT are to provide a diagnosis, either whether there's a benign or malignant condition, and to gain sufficient material for ancillary testing. Occasionally we do staging, but mostly that's just diagnosis. And the aim of the rapid on-site evaluation is hopefully to be able to stop the procedure once we have sufficient material and avoid prolonging the procedure. On the flip side, it also allows us to keep going if we need to. If we haven't got the material there, then we can keep going until we have sufficient material. And the latest guidelines, the American guidelines, do suggest that the ROSE is used where available. So collaborative working is a two-way street. So first of all, it's really important that we have a conversation with the clinicians before we
Hello, Jared, we may just have an internet issue here. You've just frozen there. Okay, looks like we might have another connection issue, so just bear with us again, please, while we see if we can address that. Hi, Jared, are you back with us? Sorry, you're on mute.
There we go. Am I back?
Yes, you are. Sorry, you'll probably have to share screen again.
Yeah, no problem. How's that?
Yep, that's perfect. We're back to the same slide. Yeah.
Okay, so did that bit pre-test positive? I'm not sure what I got to. So essentially, it's very important to know if, what the pre-test positivity is. Are we looking for malignant if we had a discussion beforehand with the clinician, they're happy just to have
Sorry, Jared, we seem to be having the same problem again. Jared, I think you're back again now. Third time lucky.
unmute.
That's it. Thanks.
There we go. So are we looking for a malignancy essentially, or is the clinician happy just to have, for instance, 2 good passes of node sampling, and then the relevant clinical history? So is there a known malignancy? What does the imaging show? Is there an infection? So that could help us look for granulomatous tuberculosis, or it used to affect what we had to wear PPE wise, but now everything's full PPE. And occasionally we'll have a known tissue diagnosis already, and the clinician will tell you they just need material for the ancillary testing for all the molecular work to see what treatment options are available. And on the other side of the road, we have the feedback that we can then provide. So there's basic sample adequacy. If it's low pretest positivity, then as I say, a couple of passes of node sampling will be sufficient to stop the procedure. But if it's high pretest positivity, we can provide more information. So through audit, we've managed to show that our ROSE BMSs can reliably cease procedures only when there's sufficient material for all the ancillary testing required. Also, we can provide guidance to clinicians as to how to sample sometimes. So if we're seeing necrosis, that can help the clinician target a slightly different area. If the volume of sample we're getting is very small, we can advise suction. If it becomes bloody, then we can reduce the suction. If what we're seeing looks like it could be lymphoma, we could suggest a larger needle, because we don't have flow cytometry at RCHT. So that helps us gain plenty of material for all the immuno. And if we see granulomas, it could indicate that perhaps microbiology is needed. So another suggestion we can make. But preliminary diagnosis, for instance, aiding patient triage, is something we do not do as a VMS at ROSE. I think Lena mentioned earlier, we use a single slide assessment here. So all the material from the pass is ejected into the lid of a universal, and we homogenize it with a pipette. Then we make a quick MGG slide, and at that point we can give feedback to the clinicians. And the benefit of this method is if we've been getting blood, and then we suddenly have a pass with good material, we can separate that out. So by taking a sample from the lid, the rest of the material hopefully should be representative, the same sort of thing. And we can put that into a separate pot to make sure that the clot we make from that, or an LBC sample, is as cellular as it can be. Here's a little photo of our setup, the hairdryer, and there's a fixative at the end. And oh, there we go. So this just shows a decision tree, I think. So it's saying my connection's unstable.
We can hear you, Jared. We can still hear you. Yeah. Okay,
good. So this just shows our decision tree while we're at ROSE, but the take-home message here is if it's diagnostic and looking malignant, it's this box here we're after. So we don't generally choose or decide whether it's SCC or adeno. If it looks non-small cell, we go with this criteria up here, and we're making sure we've got enough material for all the PDL1, ROS1, ALK, and EGFR. If it looks like small cell, we know that's a much smaller panel, if anything, needed. If it could be melanoma, then we need enough for immuno and BRAF, and lymphoma, as I say, we could suggest a larger needle to get all the as much as we can. So I've got just 3 cases for you, just to exemplify this. So the first case, a 61-year-old female. She had extreme lymphadenopathy and liver mets. And importantly, she had SVCO and a high pretest positivity. So very quickly during this one, her oxygen saturation dropped to 88% on 4 litres of oxygen. So it's quite crucial to end this one as soon as we could, really. So at low power, you can't really see what's going on, but it's very cellular. And there was plenty left in the lid for any testing. And on high power, we had this sort of thing. So I'm going to go to the first poll now. What's your decision as arose? Is it non-diagnostic, given the high pretest positivity? Is it diagnostic and sufficient to stop, or diagnostic and we need some more material?
That poll's now up, Gerard, so I'll give it about a minute for replies.
Jerry, could you just move back to the image so people could have a look at the image before polling?
Yeah, I can certainly try. Stop this. It's automatically going to restart in 22 seconds, apparently. No, there's no cancel. Apparently, my laptop's about to restart in 15 seconds. There's nothing I can do. There's no cancel button.
Okay.
Well, I can tell you on that one very quick. About 8 seconds. It was a small cell, and so we were able to stop, which is very good news for the patient. And I think we're going to go.
And 72% had actually said diagnostic and material present and sufficient. Okay, everyone, I'm guessing that we may not be able to go back to the teams there. We'll just see. There's James. Hi.
Hi, Alison. We're having a bit of a nightmare. Apparently the whole county internet signal is out. So we did try with doing a link, but that was via someone's mobile signal. But I think we're going to unfortunately have to finish it there because we're not succeeding by keeping up internet signal, I'm afraid.
Well,
so apologies to everybody, but we can work with you to try and get something on YouTube so that the full videos are available afterwards if people would like to see everything in entirety without the blips in between. So apologies from everyone here, but it was kind of out of our control.
Absolutely, and I would just like to thank you and your team, and a great example of collaboration.
It definitely worked together today, that's for sure.
Exactly, and that was definitely outside your control, but thank you for persevering, and we do really appreciate that. And it was a great series of cases. And again, some really rare examples. So it was really good to see those. And again, excellent images. And we've got lots of thank yous coming through now. So, and obviously IT problems. Things can't be helped. But thank you again to you and all the presenters today. We really appreciate you taking the time to do these. And as you said, we will work to get those available onto the BAC website and onto our YouTube channel. So thank you again. Thank you, everybody.
You. Take care.
Okay,
bye.
Thanks. All the best.
Care.
Thank you. Okay, everyone. So thank you for attending our BAC webinar. And again, I think despite the internet issues, I think that was a great start to our webinar series for 2021. We will update you with the series of presentations that are coming through. That we will have coming up through spring and into the summer. So thank you, everybody, and take care. Thank you.